I'm David Hepner. I'm from the United States. I'm the president of the Society for Perioperative Assessment and Quality Improvement. And Monty Mython and Mark Hamilton kindly invited me to talk about perioperative anaphylaxis. So what we do with latex allergies, we get a very good history and physical beforehand, because identifying the patients, it's much easier than to treat them. So once we identify patients that are at risk of latex allergy, then what we do is we inform the operating room. They have a latex-free operating room, and ideally it gets done as the first case of the day. So that's beforehand. As far as treating it, if you suspected intraoperatively that you have a case of latex allergy, it's the same treatment as for any type of anaphylaxis, the ABC, airway, breathing, circulation, and the early use of epinephrine. There is no role for preemptive measures for someone with latex allergy. At the very beginning, people were suggesting about using H1, antihistamines, H2 blockers, steroids, but the data is that it really doesn't do anything. It may just actually delay the presentation or make it even worse, because you're masking the early signs of anaphylaxis. So nowadays, no, it is not recommended to prophylax. So as far as how could you predict that the reaction is going to be severe with anaphylaxis, it's the faster the reaction happens, the more likely it's going to be severe. The more need for epinephrine, the more epinephrine that you need, the more likely it's going to be severe. There are some factors that make anaphylaxis worse, like such as being on beta blockers, having cardiac disease, having asthma. They're not risk factors per se, but they will make it more difficult to treat. Myths about anaphylaxis. One is that you're allergic to local anesthetics. That's almost unheard of. That's usually systemic absorption, intravascular absorption. There's some myths that you cannot use propofol in someone with a history of egg allergy. That's not true, because if you're allergic, you're usually allergic to the egg white, and the propofol, the egg component of the propofol is in the egg yolk, which is highly purified. Also, some people say that you could be allergic to opioids. It's usually not an allergic reaction. That's usually histamine release. As far as penicillin and cephalosporin curse reactivity, a lot of the allergy books still quote about an 8 to 10% curse reactivity, but that's really not true. A lot of the early reports of curse reactivity were with first generation cephalosporins, which actually had some trace of penicillin. Also, patients that are truly at risk or that truly have an allergic reaction to penicillin, they're more likely to have an allergic reaction to anything, not just cephalosporin. And finally, there's a very nice review, Pinchero, that actually demonstrated that it is mainly the side chain structure. So as far as a first generation cephalosporin, there's probably increased risk versus a second or third generation in which the risk is non-existent. The treatment of anaphylaxis, it's an important concept. It first goes back to basic principles. As I mentioned, the airway, breathing, circulation, and the early use of epinephrine. About 10% of cases of anaphylaxis may present with bradycardia, but those are the cases in which you do not want to give atropine. The reason for that is that that's seen in major hypovolemic states. You could actually get this paradoxical bradycardia, in which should be treated with fluid resuscitation and epinephrine. So again, stay away from the atropine. The epinephrine, you have alpha-1 receptors, which is vasoconstriction because of the massive vasodilation that you have with the anaphylaxis. Also, you have the beta-1 receptors from the epinephrine, that it's inotrope and chronotropy. Also, like if you were to have this bradycardia that I was referring to, so it's also good. And also the beta-2 receptors, it's their bronchodilators. Anything that actually it blunts the increase of the nitric oxide, arginine vasopressin. There's actually a case report with methylene blue that it's actually also helpful. So perhaps that's the direction that we're heading. I think it's also very important because it has a very high mortality and morbidity, and not many people are exposed to anaphylaxis, is to have simulators where you could actually have cases of anaphylaxis, and then the consultants could go to simulators and participate and learn how to diagnose and manage anaphylaxis.